All right, everyone. I have Megan Heaton here today, and I'm so excited to talk to her because we are going to be talking about VBACs, and it's a subject that we are both really passionate about. Me being a birth worker and just seeing some of the experiences that I have, or having friends too scared or being told that they can't have a vaginal birth after cesarean, being told
Mhm.
that it's too risky, it's too scary, that maybe they're not a good candidate, but actually looking at the research and the statistics and being present at some amazing VBACs where you're like, yes,
Right?
yes, knowing that it's so possible when you have providers that are supporting physiological birth. So Megan's going to come on and just share with us her experience, her passion
Yeah.
behind it. And she has an amazing resource called the VBAC link and what led her to start this all. So thank you so much for coming on the podcast today.
Yeah, thank you for having me. It's an honor. I obviously love talking about VBAC. It is a special place to my heart. And it's something that I want so badly for everyone to hear about. But at the same time, it's really important to me that my followers, that anyone listening, oh, sorry here. My phone's ringing. That anybody listening also knows that sometimes VBAC isn't the right option all the time.
Mhm.
And so, although I'm VBAC passionate and like probably sound like I'm just spilling VBAC and like so pro VBAC, I'm not anti cesarean. And so, I just kind of want to like let everyone know as you're listening, know that, as you're listening, if you feel like this is the right choice for you, go for it. There's so much information out there. But if not, that's okay too. Um, but yeah, I actually became VBAC passionate based off of my own personal journey. I had my first baby. I had my OB that I had because my mom went to him and everybody else in my family went to him. And I got pregnant and just did the thing. I went in, asked the questions that I thought I should ask, and was expecting to have a baby. And when it came down to having a baby, I wasn't expecting the lack of support, I guess. I expected more. And I don't know why I expected more, but I did. I hoped for more. And when that birth ended in a C-section, uh, I was kind of shocked, but in one way I wasn't because my mom, my aunt, and everybody like that had gone to this OB that I knew had C-sections. But I
Mm.
just, followed through and just went with what everybody did, and it was fine. But yeah, I had a cesarean, and it wasn't desired, and it was hard. It was really hard for me because I wasn't expecting it. And then with my second, I wanted a VBAC. I started learning about VBAC. I'm like, oh my gosh, I can have a vaginal birth. And my doctor had told me nothing about that, which through working with the VBAC link here, I'm finding that's more and more common. These people just don't know it's an option. In fact, I think it's the American Midwife Association or APA Pregnancy Association. They say that like up to 90% of people are candidates, but only 10% are even given the option to try,
Mm.
which is kind of mind blowing and saddening because there are so many of us out there that are being told what you're saying your friends are being told, right? Like, well, you probably just need to have a cesarean or you'll never be able to have a baby.
Mhm.
So anyway, I stayed with that provider, and in mid pregnancy, I decided I probably shouldn't be with that provider. Like, I had this feeling. But then something was like, well, you can't leave. You've already gone this far. Like, that would be wrong. Like, I felt like I had this thing, like this contract that I couldn't break with my provider. And anyway, and I kept telling him I want a vaginal birth. And he's like, yeah, no problem. Sounds cool. And then it came down to me being in labor, and the support was gone. And he started pressuring my husband and scaring my husband. And lo and behold, I walked down for a second repeat cesarean. And anyway, right after that, that's kind of where my journey started. I was like, no, I want to be someone that supports people and helps them know their options and really dig into this because I don't want anyone to feel the way I felt because that felt crappy, really
Mhm.
crappy. And so yeah, I signed up to become a doula, a birth doula, before I even left the hospital. So I was Googling in the dark recovering room, nursing a baby, swollen eyes, how to become a doula. And it was like fire inside of me. I don't know if you've ever had that feeling where you're like, oh my gosh, like all the adrenaline, but I knew this is what I wanted to do. And then through me being a doula is where Julie and I partnered and created the VBAC link. And it as supposed to be something small just here in Utah. I'm here from Utah, and we were just going to say Utah VBAC link. And then we quickly realized there's so much, it needed to be bigger. And so we created the VBAC link, and now here we are educating on VBAC and sharing it with the world. And then also educating birth workers through our VBAC course to go out and change their world, because I'm just here in Utah. I'm by myself. I can't change the VBAC world alone, right? And so, all the birth workers out there and all the parents listening, it's so wonderful to be able to like spread the word.
Mm-hmm.
Yeah.
Yeah, that's so amazing. I know, so for people listening who want a VBAC, a couple of things like that I'm hearing you share through your story, and also like research just shows, is first of all, finding a VBAC friendly provider. And
Yes.
that is so critical, because like so many are told like, yeah, of course you can try for a VBAC, blah, blah, blah. And it's like, okay,
Mhm.
but what are your actual statistics? How many people, I would ask your provider, like how many people
Mhm.
have a VBAC here? Like, what do you tell people to ask their provider? Like, what are you telling women? Like, okay, you want a VBAC, you think your provider's VBAC friendly. Here's some questions you should ask.
Absolutely. It really is one of the most important roles in your VBAC, is having that provider that is supportive. And so, some number one questions is, first of all, never ask a yes or no question. I know it sounds really silly,
Right. Do you allow
but
VBAC? Yes.
yeah, yeah. Hey, do you support VBAC? Yeah, no problem. Do you like VBAC? Yeah. Like it's just so easy to say yes or no. But when you have a provider that you ask an open-ended question and they are forced to actually respond, that will help you know if your provider truly is supportive. So some of the questions is, what are your thoughts on VBAC? If your provider is saying things like, oh, well, it happens from time to time and I support it, and, but there's some restrictions and there's some big risks, okay, then let's talk about those risks. What risks do you have? Why does it happen time to time? What are your statistics? If a provider says, I don't know, that's a red flag,
Right.
because they know. They
Mm-hmm.
know how many cesareans, they know how many VBACs, they know the type of care that they provide for VBAC. So if they're like, I don't really know what my stats are, that's concerning. And like you were saying, like some offices can be 75%, and that's amazing. And those offices know.
Right.
They know that they're VBAC supportive and they know their rates are high. So talk to them about that. What are your stats? Another one is, what restrictions do you have for VBAC parents? Because that right there can be a big one for you determining if your provider is actually supportive or not. Because if they're like, well, we don't really have that many, but we do require you to have a baby by 39 weeks. It has to be spontaneous. You cannot have any Pitocin. Your water can break, but that's, it has to happen spontaneously. We can't break it by itself, or we can't manually break it. Like all of these restrictions are problems. Another thing too is, do you require growth ultrasounds and cesarean scar thickness, right? Like there's so many providers out there like, oh, well, I'll totally allow you to VBAC, but if at 38 weeks we're showing your baby's over 8 pounds, we can't. Has
And
to be
we
a scheduled
we all know
C-section.
how like inaccurate those
Yes.
those are. It's like
No,
it's
it's
not even close to
not
accurate.
even close. I mean, once in a while we'll have an
Right.
ultrasound and it will be like pretty dang close, right?
Mm-hmm.
But then we can have an ultrasound that shows your baby's 10 pounds and they're like, oh, well, you could plus or minus 1 or 2 pounds. And you're like, 12 pounds. Oh my gosh. And it starts scaring us, right? That is more than likely inaccurate. Like 12-pound babies, they do come out, and they come out vaginally, 11 pound, 12 pounds. But yeah, those ultrasounds, we don't need to be doing third trimester ultrasounds for no reason other than to check a baby's size. That's
Mhm.
just not, not needed, right? So there's all those questions. So open-ended questions. Another one is, will you be the provider that is catching my baby? Will you be working with me during my labor journey and birth journey? Because if you have a provider that's totally supportive and you're like, yep, that's the person, and then they work in a practice of
Mhm.
5, 10, 12, and Jack, Jill, Jane, and Sally are not supportive and you get them, that could be a problem too. And it makes it so you have to go into your birth fighting. And I hate it. I hate that feedback has to go in feeling like they've got their gloves on. But I'm going to tell you right now, it's just real. That's how it is. Like a lot of the times we have to go in and we have to have our boxing gloves ready to kind of knock down what we don't want. And I hate it. I hate that we have to fight so hard because we are just parents going in to have a baby,
Mhm.
but we're not viewed that way, right?
Yeah. Mhm.
So
Well,
yeah.
one thing, so you were saying like I was mentioning before the podcast how the World Health Organization recommends that the C-section rate be at 10 to 12%,
Mhm.
where the United States were at 32.
Mhm.
And then a lot of places, the overall VBAC rate in the United States is 13%. And the practice that I formerly worked at, it's 75%. Like, how amazing is that? I literally tell everybody in my
Mhm.
area, I'm like, I don't care if it's an hour drive, you need to go birth at this place because
Yes.
I worked there. I see how amazing the staff is. Even the nurses at this hospital are so amazing.
Mm.
Like every single person, is so supportive, and it was such a cool experience to be a part of. And like you're saying, if they don't know the statistics, then they're not supportive, because
Yeah.
this place is advertising, look at how big our VBAC rate is, we
Yep.
want you to come birth here, we want you to have the experience that you want, like we
Mhm.
want to give you that chance to get
Yeah.
the birth that you want, so we are
Yeah.
telling you that this is what it is, these are our
Mhm.
statistics. um,
Mhm.
and so you were saying like also that parents shouldn't have to go in fighting. And that brings me kind of like to my next thing. I didn't know that you had become a doula, but having
Mhm.
doulas and that support decreases the cesarean rate. And then it
Yeah.
also takes a little bit of pressure off of you because you just already feel there's somebody on your side. There is
Yes.
support for you there. They know the research, they know the statistics, they know you, your plan. Like they know that maybe you
Mhm.
had this experience that you didn't want and you want something different this time, and they are going to be with you every step of the way. So whether that provider's in and out of your room, and then
Mhm.
you get Sally who like doesn't like VBACs,
Mhm.
you are going to be reminded in that experience that you have a voice, you have a choice, and that there's other things that you can do to ensure the safety of you and your baby while you are trialing for a vaginal delivery, that
Yes.
maybe your provider is not telling you.
Yeah. And that's kind of really, I mean, so my second, my TOLAC, which is trial of labor after cesarean, for anyone who doesn't know what a TOLAC is. I had my first nurse when I got there was a doula before she became a nurse.
That's awesome.
And I wanted a doula at 30, like at 37 weeks, I found out about a doula. Don't know why it took me so long during my journey to really like learn more about a doula. And my husband actually wasn't supportive of it. He was like, no, no, I'm not being replaced. And, like he was kind of like really upset about it actually. And I was like, it's not like that. But anyway, my nurse was a doula and I was like, yes. So then I became a doula, and with my VBAC after my second cesarean, we had a doula, and my husband was like, game changer. Game changer. Not just for me, but for him. And
Right.
he really felt the difference. And so yeah, I am a big advocate. I mean, not just because I'm a doula, but I've experienced like doula care personally, right? For my VBAC. And my VBAC was long, it was hard, it was a rough journey. It was rough. But my doulas were right there. They were helping me, they were helping my husband. We were working on that baby's position because we knew it was off. And truly, in all honesty, I to this day will say I had that VBAC because of my team, because of who I chose on my team. And I wouldn't have ever shamed anybody if I didn't end up having a VBAC. But that doula made a difference. And doulas do make a difference. We are educated in birth, and I like to kind of explain it like a doula sandwich. So I, as a doula, know birth better than usually most partners are going to ever even want to know birth, but definitely going to get to know birth in the short period of time that someone's pregnant, right? And they know their partner more than I'm going to get to know them in this 9-month period of time, or less, because sometimes we get hired 6 months, right? And so together we get to come together, love, educate, and support this person and help everybody feel supported during their journey. It's so important. And like you were saying, like if Sally comes in and is like, hey, we have to do this, 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 and this, and I'm laboring, I am not in a headspace that I can be like, oh yeah, I know what all of those are, and I'm fine with it, or I'm not fine with it, right? Like, so to have a doula there to break it down for you and your partner and anybody else in the room is so nice. You don't have to be in that mental space of a book and a laboring mom and, and all these other places.
Right, exactly. I love
Mm-hmm.
that you shared that, because I've heard that from a lot of people that maybe their partners weren't on board, and
Mm-hmm.
when people are like, well, are you going to replace my husband? Like, what about my husband? And I'm like, is he a birthing expert? Has he
Yeah.
studied labor? Does he know the physiological birth? Does he know the signs? Does
Mm-hmm.
he know what's normal, what's not normal? So when you're
Mm-hmm.
puking your brains out and he's freaking out and you're
I
shaking
know.
uncontrollably, I'm like, this is normal. Like,
Yeah. Yeah.
like,
And they're like, what?
right. They're like, I
Yeah.
don't know what to do. I don't know how to help. And we also just give them a role. Like, it's so
Yes.
nice to be like, hey, here's how you can best support her during this time,
Mm-hmm.
versus not knowing what to do, not knowing how to help. I've had
Exactly.
so many partners be the advocate for having a doula. Like, after experiencing it, a lot
Yep.
of them have been hesitant. Like, I don't want to be replaced. And then, we have that conversation.
Mm-hmm.
Like, I'm not here to replace you.
Yeah.
And again, that's something that the research speaks for itself. Like, they did research on laboring women who had support, doula support, or just like a birthing support person there just for
Mm-hmm.
them, and interviewed them 20 years later. And they had fonder memories of their partners during labor than people who did not, because we make
Mm-hmm.
them look good. We make your partner shine.
Yes, seriously though, and honestly, we help take trauma out of for the partner too, because sometimes when they're seeing their loved one vomit and shake and not be loving the moment, it can be very scary and overwhelming, and they want to help, but they don't know how to help.
Right.
And so we can, one, calm them down, let them know what's normal, what's not, and two, help them know how to support. Like my husband with my second, he was literally shoved in the corner, really, until my nurse came, and then he was actually tired, so she was like, I got her, you can go ahead and sleep. Which was nice for even my VBAC. My husband was so tired and he was able to go to bed, and my doula was able to stay up and work with me and support me too. So yeah, it's a crazy thing, but doulas are a big role. And like you said, as nurses, like nurses at your facility that you're talking about are amazing. And I don't think nurses are ever bad, but you may have a nurse that's not maybe as VBAC supportive as well and has a little bit less patience. And so to have your doula be there actively with you, they can help walk through and even communicate with the nurses.
Right.
Mm.
Yeah,
I
absolutely.
don't know how to respond to that.
Man, I'm a mess. Thank you, Watch. Doesn't know how to respond.
So I'm just looking at like some of the statistics, and it's interesting because you can kind of see when the stats went up. Like, for at one point in the United States, VBACs were at a 28%, which is a lot higher than they are now. But a big change in it came in 98 and 99 because of the OB male in practice insurance premiums were rising, and because of some not great guidance from ACOG, which sometimes has like a lot of amazing information out there. But during this time, they were saying that if an anesthesiologist was not immediately available for women attempting a VBAC, that they couldn't do it. So a lot of places didn't have an anesthesiologist on call all the time, and so they shut down that option, and that like skyrocketed the repeats cesarean, right? And like the the VBAC rate drastically declined.
Yeah.
The nice thing is from 2004, it was at 9%. Now it's at 13. So, but that's like such a slow increase over the last like almost 20 years, like
It
3%.
is. Yeah.
It is super, super slow. Um, but I mean, there was, I think at one point that like 30% of hospitals banned cesareans.
Yeah. So
So,
it's called a VBAC ban.
mhm,
And unfortunately we still have way too many facilities out there that have VBAC bans. And like you were saying, you're like, I don't care if it's an hour away drive, I don't care if it's 2 hours drive. Some people don't feel comfortable, which I understand. It's intimidating, but sometimes they have to drive or they even have to leave their state.
right. I know. I've already been prepared myself to leave my state if I'm ever breech or twins. I'm like,
Mm-hmm.
I'm driving over the border to Wisconsin or Indiana
Mm-hmm.
because each of them are
Mm-hmm.
only an hour drive. So I'm like, I will absolutely be driving over because
Yeah.
there's like, it's so hard because I probably wouldn't know that I'm breech until like a certain point. And then
Mm-hmm.
there's only a couple of doctors here that do deliver breech. I've heard that there's
Oh.
a couple more, but like where they practice, like they've let a few breech
Mm.
births happen, and like the hospital was so pissed off that like where they
Oh.
practice pretty much doesn't allow it. So I'm already like, all right, if I'm breech or I'm having
Mhm.
twins, I'm going north or south.
And I think that started around 2000 where breach just started going away. And it's not
Right.
even really being taught very well in schools to new providers. I mean,
Right.
it's going away, but really it's just a different
It's a variation of
norm. It's a
normal.
variation and yeah, it's not bad.
Right, right,
And it's still possible. And Dr. Stu in California, he talks about it and it's like, why?
right.
Why not?
Yeah.
Like,
I had him on the podcast last winter and we had a
oh,
great episode on it. And I listen to his Birthing Instincts podcast all the time. And I
me
just
too.
love him and Bliss and a lot of the information that they're putting out there. It's a really great resource if you're interested in learning more about breech birth. Um,
Absolutely.
but like, so I had mentioned like at the beginning that there might be some
Hmm.
fear tactics that doctors are
Yes.
telling you. And I just want to go over some of those numbers because they might be like, well, your risk of rupture significantly increases, but
Yeah.
the actual numbers, the risk of a uterine rupture for people who are having a trial of labor after cesarean is 0.47%. So that's
Yeah.
half of a percent. And the use risk of uterine rupture for people who are just having an elective repeat cesarean is 0.026%. So there's still a risk, but they're both
Yeah.
super small.
And did you know that it's 0.07% chance of rupture without any previous cesareans?
0.7. Is that what you
Zero
said?
point zero point yeah, 07. Yeah. So no, small. I'm not saying that's big at all. I'm just saying there is still a risk of uterine rupture without any previous
Right.
cesarean.
Right. So that's like I mean, I think it's pretty I would say that it's small. But
Yeah.
some things that somebody might tell you is that let's see, it's 9 times you're like 6 times more likely to
Yep.
rupture. And it's like,
Yep.
okay, but that goes from 0.07% to 0.47%. So you
Mhm.
having the actual numbers, the actual like
Yes.
numbers to know what's going on um, can help you make that decision. For some people, they
Mhm.
might be like a half of a percent is too much for me. And for
E
other people, they
Right.
might be like, I'm gonna give it a try, you know,
Yeah.
and also there's things that you can do to decrease the risk of that happening, and that is not having Pitocin. It's
Mhm.
about 1% if you have Pitocin, the risk.
Yeah. Yeah, and I think too it's a matter of how that Pitocin is administered.
Yes.
So Pitocin can get like so many providers out there these misconceptions of we can't induce, we can't use Pitocin, but they can use Pitocin. Does it increase things? Yeah, it causes more pressure on the uterus to contract harder and not natural, right? But yeah, it I think a lot of times it's how it's administered. Sometimes I call it pit to distress, where we're just
Right.
upping it 4 milliliters every 30 minutes, boom, 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 boom. And then our uterus is like, whoa, 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 too much. And then our labor kicks in naturally ought to. So then we've got natural oxytocin and pitocin and too much, right? So that's where we increase is if we pit to distress, but
Right. Which you do see a lot though, because they're looking for this like perfect pattern of labor to be going
yeah.
on. So even that
Mhm.
monitoring, and depending on where you're birthing too, what makes a really big difference is intermittent versus um,
Continuous.
continuous monitoring. So continuous
Mhm.
monitoring, you're going to see an increased cesarean rate with not better fetal outcomes. So the C-section rate goes up because they're looking for any little thing that's going on with the baby, but
Yep.
they're not actually saving the baby because the fetal outcomes aren't better in these situations. So intermittent monitoring can really save you from having a cesarean. And then if you're
Yep.
trying for a VBAC, that's another thing that you have to talk to your provider about. If you're having a VPAC, are they continually monitoring because they're looking for anything? And I'm sure there's not tons of OBs that would support intermittent during
Yeah, so
the
that's one of
walk.
the main requirements that I'm pretty much discovering nationwide.
Right. That
Really.
if you're gonna VBAC, you have to have continuous monitoring.
It's non-negotiable, but it is negotiable. I want to
Mm.
say it is negotiable. It may be non-negotiable and against policy, but there if that thing is like so important to you, then it's okay. You can say, I'm not going to do this. You can do it every 15 minutes. You can do it every 30 minutes, but I'm not doing it. So, but it's a requirement all over. And that's what's hard because we see these stats and so taking these stats and saying, okay, there's this and there's this, but and these don't change the outcomes. But for VBAC, you want to do it because you're monitoring for rupture, which is usually why they're doing it.
Mm-hmm.
But there's all of these other signs as well. And so you can say like, I'll watch out for these, or I'm okay to do extra monitoring. But if you don't want to, you don't have to. But it is something that a lot of providers say, oh, if you're going to TOLAC VBAC, you have to.
Right, right. That was something that, yeah, I'm like, I just couldn't see like maybe a lot of providers being
Mhm.
supportive of just because they want to, that
Yes.
what was I saying before, the
It's a
insurance things
reassurance. Well,
like thing
it's
of
a
the hospitals.
reassurance. Yeah, it's reassurance for them, and it's for insurance and liability and all of that. They have everything's completely traced,
Hmm.
so they have all of that information. But like you were saying, like we have seen so many times where a heart rate will drop and it's like freak out, rush to the OR, but then just the movement that they created getting the mom to the OR changed the heart rate with the baby. So sometimes it's movement. So know that like uterine rupture, one of the main signs is heart rate dropping, but movement and things like that can change it.
Right, right, exactly. So that's also again where a doula comes into
Mhm.
play, like
Yeah.
helping with all of that.
Mhm.
Um, so much information is like given, I guess, like let's say you're going to your provider and they're like, listen, your risk of your placenta rupturing or your uterus
For
rupturing
uterus.
starting is
Mhm.
like significantly increases. It's 7 times more likely to
Mhm.
happen. But the thing that they failed to tell you is placenta accreta. And that's a part of the
Mhm.
conversation that's left out a lot with the risk of repeat cesarean.
Mhm.
They're not mentioning that. Whereas for those listening, placenta accreta is a serious pregnancy condition that occurs when the placenta grows too deeply into the
Into
uterine
the
wall.
uterine wall.
And
Mhm.
if this happens, the maternal death rate increases at 7%. So this is something that you don't want to happen. But when you have repeat cesareans, with the second cesarean, your risk goes up 0.3%, and with the third, 0.5%, and with the fourth,
Mhm.
2.1%, and with the fifth, 2.3%. And then with the sixth, it goes up to 6.7%. So a lot of physicians are recommending repeat C-sections, but your risk of placenta accreta, which has a greater death risk, increases significantly
Mhm.
versus the risk of your
Uterus.
uterus
Yeah.
rupturing.
Yeah. Well, and I want to talk about too. So when we talked about VBAC and then we talked about um like we talked about VBAC, but I want to also talk about the and non-VBAC, I should say. But like VBAC after multiple cesareans, the percentage too. So when I was preparing I wasn't even pregnant yet, and I was going to find providers because I really wanted to find a provider that truly supported me because I didn't want a third cesarean. And I did. I had one provider tell me that I was 10 times more likely to rupture. And if I were his daughter, sister, wife, anybody, he would strongly not suggest IV-VAC. Right. So when you're hearing that 10 times, and you're like, whoa, and you hear everybody else talking about how high it already is, and then now you're like, after one, and now you're like 10 times higher than it's already high, it's just overwhelming. But really, it was like 1%,
Right.
1%. And I was like, that's fine with me. And research shows that 71% of VBAC after multiple 2C sections will be successful, will
Hmm.
happen, but that could be higher too,
Hmm.
based off of a lot of steps that we take.
Right, right. If you're choosing the right provider, it's going to have higher percentages. Like I said, that practice that I used to work for um, has a 75% feedback rate, but
Mm-hmm.
they're also bound by some hospital practices as well because they're midwives working under OBs in the hospital. So there are some situations.
Mm-hmm.
Um, I mean, I even gave birth to my first there, and I'm
Mm-hmm.
so, so grateful for my team, like my doula, my midwife, um, because they they fought for me. Like when I was pushing my daughter out, when a nurse busted into the room and says, the OB wants to know why you're not prepping her for a C-section right now. And
What?
and my midwife goes, she's literally pushing the baby out, and like yelled at her basically and was like, and like shook her head and was like so pissed off
Oh,
because she knows that there's going to be D cells. Like at that point, I had gotten an epidural.
yes.
I was being continually monitored, and that she knows that there was some D cells. The baby was having a little bit hard time recovering after them, but she would never put my life or my baby's life in danger or at
Mm-hmm.
risk.
Mm-hmm.
And she, but the OB was in the back, like looking at the screen, being like, why aren't
Why
we
aren't
putting
we having a C-section
and
right
she's like,
here?
I'm looking at the head of the baby right now. Like, and I pushed her out like within
Oh,
20 minutes.
yes.
But like it was that provider, that team. I'm completely convinced that if I was birthing anywhere else, I would have had a C-section with my first. And
Mm-hmm.
so they really fought for me. And I know part of it too is like I worked with them. Like I became friends with
Yeah.
them. Like they're my people,
Yeah.
So
Yep.
it was awesome that they were there, but they have that high C-section or that high VBAC rate, but they're still under OBs and hospital practices. So there are
Yeah.
certain like the criteria for VBACing still has to
Mm-hmm.
be met. Like in order
Yep.
to birth at this hospital, it's like,
Did you
okay,
have to interview with a provider? An
no,
OB? Oh,
uh-uh.
that's cool. Yeah.
Yeah, wait, well, during my pregnancy, I had one appointment. Yeah,
Okay. Yeah.
with an
Yeah.
OB. Yeah.
A consult.
Hmm.
Mm-hmm. Yeah.
Yeah, which was nothing.
Right.
She just
Yeah.
came in, asked a couple questions, and left. That was it.
Mm-hmm. Yeah.
So,
But
mhm.
that's very common when there's OBs under, I mean, midwives under OBs, is that the OBs have to like sign off
Yeah,
for that. Yeah.
right, right.
Yeah.
So yeah, it was it 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 is really important, like where you're choosing, and like you said, that number would be higher if practices
Yep.
were following physiological birth and honoring
Yes.
the wishes of the mom giving birth, because a lot of times that kind of like goes out the window as well.
Yes. And I feel like there's so many times where, like during pushing, right, we have baby's heart tones kind of dropping, and sometimes they take a little, they're like prolonged, and they take a little longer to come up. But again, we're pushing, there's compression. Sometimes too, during pushing, like the uterus doesn't just relax right away. So we're not feeling the intensity to push, but it's not like totally relaxed. So there's those things too. But like, yeah, OB is also understanding that like changing of positions can truly make a difference with that, going back to position changing, like a simple, even if you're on your back, a simple twist to the side and just opening that pelvic space just a little bit more to create more space for that cord or that baby or whatever is causing these D cells. It can make a big difference, but we're so stuck in this world of like birth has to look like this,
Hmm.
knees in the elbow or knees in the armpits, everyone curled, doing the biggest ab workout ever, 9 months pregnant, pushing out a baby. Like we have to look like this
Right.
during pushing, or we can't have babies. And it's like, wait, 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 wait. let's stop that. Let's figure out what more we can do, because I truly believe a lot that a lot of parents that go to pushing and then their babies are dropping and then they're rushed down to the OR, that it could be changed based off of just trusting and understanding dynamics of the pelvis and the body.
Right, right. Like, I mean, even more that we dive into it, you like learning that your knees out to your elbows is actually, or your armpits is actually closing the pelvic floor versus your
Mhm.
knees in together is
And
opening
yep.
it up, creating space. So yeah, the traditional positions that they have pushing
Yes.
happening in is not normal when you, especially when you go all
No.
the way back and you're looking about how we've been birthing
Squatting.
for years, right? Squatting,
Yeah.
and just even, yeah, the positions that really work well with the body. And the one
Mhm.
thing that I always tell people too, like if you get an epidural, you can still do different positions, but that's
Yeah.
another thing to ask your provider. And
Yep.
because some places are like, you have an epidural, no, you have to like be on your back then. But
Yeah.
even just rotating the side to side with the peanut ball, some
Mhm.
places I've been at epidural births where we were able to help get them into hands and knees. We were able to use
Mhm.
the squat bar. We were able
Yep.
to do different tactics because we were like, wow, like this position's not working well. Let's try everything that we can
Yes.
and do, help you help the baby get out. So
Yeah.
finding providers that are going to be really supportive in that is super super important. And I want to go back because like you had said, at the beginning you just went to the doctor that your whole family went to, and that's
Mhm.
who I initially like interviewed when I came here, and he told me that you have to birth on your back. And I was a doula at the time. So I was like, okay, well, that's stupid. I'm
Yeah.
obviously not birthing here. And I'm so glad I found the practice that I ended up working at. And, but you stayed with them. And that's
Yep.
like another thing I wanted to address because this is, I guess, as a birth worker, um, where I struggle, like with family and friends who don't understand what I do, who aren't going to hire a doula, who they're like,
Mhm.
I had a cesarean with my first, I really want a VBAC for my second. And I'm like, okay,
Yeah.
maybe try a new provider, or maybe, and they're like, well, I trust my doctors. And
Yes.
it's like, what, it's hard for me to wrap my mind around, because I'm like, well, do you
Mhm.
want a VBAC or do you want to just trust your doctor? Like, you know what I mean? Like, it's hard for
I
me
get
to.
that. Oh, it's one of the hardest things actually, I think, as a birth worker, because it's not our place to say, yeah, you're in the wrong place, you should switch. But at the same time, we're seeing these like major red flags, and it is, we can educate, right? We can educate them and say like, okay, here are the red flags, and encourage them to talk with their provider. But in the end, it is up to them to either trust their provider or move on. And I trusted my provider, and it totally backfired. And I'm not saying that that's going to happen for everybody, but really, that's the big question, like what you said. So, do you really want to be back or not? And it's okay if you don't. That's okay
Right.
if, or it's okay if you're like, I actually feel very confident where I'm at, and I'm going to do the best I can with the provider that I have, and I'm okay either way. That's totally fine.
Hmm.
For me, I interviewed 12 providers with my VBAC baby, because I wanted something specific. And at that point, I had been become a doula. I had learned so much more about VBAC, and I was in a very different place. But I knew those red flags, and I didn't want anyone telling me I had a 10 times more likely chance of rupturing. I didn't want anyone to tell me, well, you can try. I didn't want anyone telling me, yeah, your OB's probably right. Your body probably can't have a baby vaginally, but we can try. Right.
Hmm.
That's what I kept getting from providers. It's like, Mm, I just don't believe that. I just don't believe that. And so it might take a minute. It might take you seeing a provider for 3 months and then realizing you're not in the right place. It's okay to switch. It was my biggest regret not switching. And I believe that I probably had a higher chance of a VBAC if I would have switched and not just stayed with my provider because I felt like I had some thing that I
Loyalty to
had to
them.
do. Yes, I had this, yes, loyalty, exactly. Like I kept saying, like, "I can't cheat on him." My friend was like, "So is he, like, your boyfriend? Or, like, what am I missing here?" I'm like, "Well, no, but, like, he's so nice, and he's been my
Did
doctor
he take a
forever."
vow to honor you and to respect you and to love
Exactly.
you?
Yes, but I kept saying, like, "I can't cheat on him," right? And then get this, with my 3rd, I had a supportive provider. I
Mhm.
had a supportive provider. He was great. And at 24 weeks, something in my gut said, you're not going to be in the right place. Although he's great, where you're going to be isn't the right place.
Mm.
And I couldn't shake it because I
Yeah.
didn't follow that with my first. And I'm mid-pregnancy again, like went through all of this trouble to find the supportive provider, found a supportive provider, and it was more the location. I was looking into the location. So that's another thing I really highly suggest, because although a provider may be supportive, the hospital or the location where you're going to birth at may have so many restrictions that they put on that provider
Right.
that their hands are tied,
Hmm.
and they ultimately are going to have to follow their policy, right? And that can be hard. So after looking at that, I was like, nope, this is not the right place. And so I changed to a midwifery care, and I went out of the hospital. My plan was to go out of the hospital, which then I got a lot of flack for,
Yeah, of course.
because everyone's like, what? You've had two cesareans and you're not going to birth out in a hospital next to an OR? I'm like, no, I'm not
Mhm.
doing that. And it just, that's where my midwife was, and that's where I felt comfortable and I felt confident in my research of HBAC, home birth after cesarean, which is a birth center, right? So yeah, it's crazy. It's crazy, but you have to deep down in your own self decide what you really want. How
Right.
hard do you want to go out and fight for
Hmm.
that birth experience? And it's okay, like I said, it's okay if you don't want to fight for it. It's okay.
Right. Right. And so if you're saying like, oh, I'd really like a VBAC, but I really don't want to interview more providers, then you just have to be okay with,
The outcome.
right. You have to be okay with the outcome. And I feel like even put yourself like, okay, how am I going to feel with the second cesarean? How am I going to feel if I really
Mhm.
don't get the opportunity to labor, um,
Mhm.
and try for this? Or if there's, as soon as I go into labor, the clock's ticking and then
Mhm.
I'm stressed out and trying to let my body open and, you know, trying all these different things. Like
Mhm.
how am I going to feel in these situations? And if
Yeah.
you're okay with it, then that's fine. That's fine.
Yeah, it's totally fine, but yeah, it's a hard one. It's a hard question, it really is. And
Yeah.
it might change along the way. You might feel really good, and then you might learn more information, and you're like, "Oh, actually I really want this more than I thought."
Yeah, yeah. I feel like it's so interesting because, like, I feel like I can be definitely more direct and open with people who are hiring me to be their doula versus family and friends who don't understand
Mhm.
or don't know, like, where I'm coming from because I don't know why, like, so many of my family and friends have been like, "Oh, I'm definitely not gonna get induced. I'm definitely whatever." And they're like, "Oh, yeah, my induction's scheduled at 30." And I'm like, what
Yeah.
happened? And they're like, "Oh, the
Yeah.
doctor, but," and I'm like, I just wanna, like, push, but I'm also
Mhm.
like, "Okay, they know what I do. They know
Right.
they can come to me
They'll
for advice."
ask. They'll
Right,
ask. Yep. I
right.
same thing. Like the whole the Arrive trial, which
Oh, geez.
could be yeah. Anyway, like people like totally got into a little kerfuffle, if you want to call it, at soccer the other day about this. There's a labor and delivery nurse, and then there's a dermatologist of all people, and then there's me, a doula, and we're talking about this Arrive trial, and it was me against them, unfortunately. And I was like spitting these things out, and they're like, no, 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 no. And I'm like, all right, I'm not gonna, you believe you, and I'll believe me, and we'll respect. And, if anybody else questions, you can go ask the person. But it's just hard. Like with people that it's hard to not want to just say it.
Right,
Like,
right. Yeah, I know. I just recently posted on my Instagram that Ben Affleck meme going around where he's just like smoking after talking to somebody. And
mm.
I'm like, me holding in all of my unsolicited birth advice when family and friends are talking to me. Like, and that's like me when I leave. I usually like call my husband. I'm like, babe, I just don't get it. I just don't get it. Like, and it's so hard for me to like
Good
be
for
like,
you though, because
don't
that
understand.
that is so hard, and I have a harder time keeping quiet because I'm like, no, don't, no, But
I know.
it's so hard. And like I said, going back to a birth worker, like there are studies that actually show that our clients are happier with their birth come and happier with us being honest
Right.
than not being honest and finding out later something else, right? And so we have to find this fine balance line as a birth worker to stay in our scope and offer the education, and the information without like full on saying you can't be with that provider, he's terrible or she's terrible, but really giving the information because they actually, our clients want they want that. And I think too, as you're hiring a doula, if you're hiring a doula and as you're hiring your provider, you want a provider and you want a doula, you have to decide if you want those people to be honest with you
Right.
because that can happen.
Right. And I also just like want to preface before like we wrap up and stuff too. As, as doulas, like we're completely in support of whatever you choose, but our job is that you
Yes.
actually have the information, that you're making informed decisions. So let's say we give you all of this information that like we shared on the podcast today, and you're like, for some reason, I just really feel I'm more comfortable having a repeat cesarean.
Yeah.
Awesome. Like we
Yeah.
are 100% there for you. It's the
Mm-hmm.
situations where you're being scared, where you're being told misinformation, where
Mm-hmm.
the like maybe you're not even given the
I was
facts
gonna say
or
withholding, where your
right.
provider's withholding information.
Totally, totally. And so our job is just to let you have the actual information. Like I said earlier, that 0.5%, you would be like, oh, that's I totally want to go for it. Or that 0.5%, you could be like, you know what?
That's
I
enough for me.
right. Or like you were saying earlier, you know what? Like I'm gonna stay with my provider and just see how it
Mm-hmm.
goes. Great. We're still gonna show
Mm-hmm.
up for you and be there for you and
Mm-hmm.
100% support you. We would never be like, you're wrong, you know, or
Yeah.
anything like that. Like that's not our job at all. It's
Yeah.
when we just hear people like blindly following stuff that isn't necessarily true when you're expressing to us that you want something, but then you're also not willing to do the work to get that result. That
Yep.
can just be really hard to listen to. But if you've hired
Yep.
a doula, you're already like doing some of the work.
Yeah, really though, a lot of the work, a lot
Right.
of the work. And sometimes doulas, I mean, I always encourage my clients, I'm like, more knowledge is power, more education is better for you. But like you have that little book right there within your doula to help back you up and support you. So there are one of the reasons why the VBAC link was created is because during our VBAC, Julie and I at the time, our journeys, there's so much information out there, right? There's so much information, and you can go from one website to another and find VBAC rate anywhere between like 1.5 to 2% to 0.4% to 1.5%, right? Like, and you're like, well, what is it? Is it 2% or is it 1%? Or is it less than 1%? And so it's so hard to get just super, super, super accurate information. And so one of the reasons why we did it is because we wanted all the information in one spot. We
Mm-hmm.
just want you to be able to find all your VBAC information in one spot. And so, yeah, that's why we created we have a course, and then we have a whole bunch of resources out there that that are like solid with really good studies. And then it's all right there on our website. So you can go and just click around and find all the information in that one spot.
Mm-hmm. Yeah,
Yeah.
absolutely. And I'll link all of that in the show notes. Make sure you follow the VBAC link on Instagram. They also just post tons of stuff on there. Listen to their podcast. Um, And before we wrap up, I also saw
Yeah.
this statistic, which was like super interesting, that the uterine rupture rate was 2.3% among people who had a repeat cesarean versus 0.1% in those who did have a VBAC. So the
Yes.
uterine rupture rate actually increases
For
with
repeat cesarean.
right.
Yeah. And it actually, so if you can picture in your mind a 9-month pregnant uterus, they've got a baby with water stretched out, all that stuff, right? And then you have a cesarean scar already or an incision. Um, a lot of the times it's happening during this, like right at as the cesarean is beginning, which is kind of crazy to think about. But
Mm-hmm.
they'll through, I mean, their scalpel, there's tons of things, but yeah, it's happening a lot of the times right as the cesarean is starting. But oftentimes providers won't talk about it. They won't
Right.
actually say that it happened.
Right. Right. So that just
Mhm.
doesn't even make sense to me.
Yeah, and I would
Like
also
most things again.
I know, right? You're like, "What?" I would also suggest to anyone listening, if you're wanting, to feedback, especially, but just in general, to obtain your op reports from your previous cesareans, because there's often times where a provider will tell you one thing in the OR of the
Mm,
reason why your cesarean happened,
yeah.
but then document a completely other thing. So, and I don't ever want to make it sound like providers are malicious by any reason. But it is a little weird that we're being told one thing and then there's another thing, right? So like I was told one of the reasons why is fetal heart tones,
Hmm.
but that's not documented anywhere in my
Really?
charts,
That's crazy.
anywhere. Yeah. I had a good category like the whole time. And the reason why for my cesarean is my pelvis was too small and
Oh my gosh.
failure to progress.
Wow.
Because after 3 hours, I was 3 centimeters.
Which we both know that that's bullshit.
Yeah. So I was thinking it was valid as we're going down to the OR that my baby's life is in danger. So I sign a paper and we're off. And then I find out 2 years later, actually, it was 3 years later because it was after my second cesarean, that none of that actually happened.
Wow.
That my baby was just fine. And I didn't have a doula there that who understood heart tracings and be like, okay, no, your baby's actually fine.
Right.
you know? But yeah, I mean, it's just it can happen. It can happen. So and then not to keep going, so I know we need to wrap it up. But if you have been told that your pelvis is too small, please don't believe that. There are situations where pelvises are not able to vaginally get a baby out. Usually like malformation or severe breaking, and we've got some major things going on, or malnutrition, but usually your pelvis is just fine. We have all different forms of pelvises all over the world, and babies mold, we move. I have so many people. I mean, I just had a client the other day call looking for postpartum, and she said, "Oh, I'm going to have a C-section because my pelvis is too small." She said that. And again, it was like one of those times where it's like, do I give her the information or do I just let it be? Because we can believe that. We naturally believe providers who went to school for years and years and years, right? Like they
Right.
went to
Right.
school, they know. But I'm not saying don't believe your provider, but I'm saying don't not question them.
Right. Right. And I mean, and research has shown too that once certain things come out, that it takes 15 to 20 years to be implemented in the medical community, except for the
Yes.
Arrive trial that came out and they're like, oh, let's induce everyone at 39 weeks.
Yeah.
Anything else that's like, hey, actually, intermittent monitoring is way better than continuous. That's not going to be starting to be
Mhm.
implemented. Like when I first started practicing in 2013 in Vegas, not one birth I went to, the doctors would let the cord pulse. Not one.
Really?
Would they do delayed cord clamping? And now
Mm.
you see it
It's
everywhere.
standard. It's standard.
Right, right. But it's standard, but not totally. Like they'll
That
let
is
it
true.
pulse for a couple of minutes. But what was
Yes.
super interesting was because in the hospital, I don't remember with my first how long it pulsed for. That was just also a completely crazy experience. But with my second at the birthing center, she kept
Mhm.
checking my cord. It was over 10 minutes. My cord was
Before it
pulsing.
stopped pulsing.
Yes.
Yeah.
And I'm
And
like, that's crazy because usually at hospitals, they're like, it's a couple of minutes. They're like, okay, it's done. And they
yeah,
clamp and cut.
it's
And
white.
right,
It's
right,
white. So it's
right.
done.
Whereas mine was over 10 minutes with my last birth.
Yeah.
And I was like, it's still pulsing. She's like, yep, it's at 10 minutes. It's still going. And
Yeah.
I was like, holy crap. Like, I
Yeah.
had no idea that it really
That it
went
could
that long,
go that
even as a
long.
doula, because most of my hospital births, after a few minutes, they're like, okay, it's
Mhm.
done.
Yeah.
So,
Yeah, and it's okay to say that. If they're like, "Okay, your cord's done. We're gonna cut it now." It's you can say, "I'm gonna feel it," and just feel it. There's the little cord right here, and you just feel it, and you can feel a pulse.
right,
If it's totally not, then you're good. But if it's pulsing, you can say, "Actually, I feel like it's still pulsing. I'd like to continue."
right, right. And I mean, a couple minutes is a lot better than,
And then nothing.
right, right.
Then nothing. And there's also milking. If there's something
Milking the cord.
crazy, you can milk it. But yeah, yeah, there are things we're so far behind still.
Right, right. But I'm so thankful for this conversation. I'm going to include all of the links in the show notes where people can get in touch with you, listen to your podcast. If there's birth
Yes.
workers who want to take your course, all of that I'll have in the show notes. And I just want to thank you so much for
Yeah.
coming on. I love these chats because I hardly ever get to talk about doula stuff and birth work on here. I'm just
Yes.
always like interviewing, just parental
Yeah.
advice or life or whatever. And
Yeah.
so this type of
Which is
stuff,
all
I'm like,
amazing.
right.
It's
I could
all
just talk
everything you do
about,
is
yeah.
amazing.
Thank you.
But
Right.
it is. It's it's kind of fun and eye-opening to dig in to
Mhm.
this. I mean, with our parents that take our course, they're like, whoa, I didn't know the full history. I didn't know why uterine rupture started. I
Mhm.
mean, like why it increased and then VBAC went down, or cesarean went up and VBAC went down because of the drug they were using, right?
Right.
It all happened by a false statement and a drug that they were using that they shouldn't have been using. And now VBAC is scary.
Right. Right. Even though the medical industry has changed so much, that it goes back to, I've talked about this on here too, about how eating and drinking during labor, how they're like, well, you could choke on your vomit and die. And it's like, okay, that comes from the 1940s when they were putting everybody under general anesthesia and
Yep.
they weren't taking proper precautions to
Yep.
like clear out. I'm like, they don't do that anymore. Like general anesthesia
No.
really happens, but even if it does, there's precautions taken so that
Yep.
that doesn't happen. So it
Yeah.
just doesn't make sense. It's like, why are we practicing something from 80
Yes.
years ago that made sense because of a drug that they were using and how they were practicing then,
Yeah.
but we no longer do.
But that's
So,
exactly, it's not even happening. There was a provider at a hospital here that I worked with probably 4 years ago, and she was so passionate about that. Like she came in and she brought my client food, this OB,
that's
and I'm like,
awesome.
what? She's like, what? I can't even believe this is happening. And she's like, oh no. She's like, we have to eat. She's like, if we don't fuel our bodies, we have crashing babies, we have crashing moms. She's like, this is important. And I was like, you are awesome. And she's like, I was so passionate during whatever in school that she wrote a whole paper, and she's like, you're more likely to be struck in the head by lightning twice than you are to vomit and aspirate, and she was like talking about this, and I was like, well, how often do people get struck in the head by lightning twice?
Right.
Like
Not very often.
not very often. So she's like, no, like my patients will eat, and they don't have to have a just in case epidural either.
Right, right.
Yeah, which is
Absolutely.
kind of interesting. Side note, after we've had an epidural, we're even less likely to go under general anesthesia, but after we have an epidural, we can eat or drink.
Right, right. Yeah. No, it doesn't make any sense. But I mean, we could talk forever about
I
the
know.
things that don't make
Yeah, no,
sense in the
we
practice.
could. We could have a whole episode times 5 on
Maybe we'll do another episode where
make
we're
this
like,
make sense.
right,
Make this make sense.
that'll be like the title of it.
Yes.
Um,
Oh, thank you so much for
yeah.
having me. It was
Thank you
so
so much
fun
for
to
coming
chat.
on. I know, and I'm so grateful for you and the work that you guys are doing. It's awesome that you guys were going to start something small, but like you saw this need and it's like
Yes.
blown up and you guys are even
Mhm.
quoted in like different things. It's like, hey, check out the vbaclink.com
Oh,
because they have
yeah.
tons there. So I just want to thank you again so much for your time, your expertise, and everything that you shared with us today.
Thank you.